Thank you for being here, and today I'm very excited to talk to you about venous disease. So we hear people with bad veins, venous disease. What exactly is venous disease? I'm hoping that I can clarify that for you tonight. When we talk about the circulatory system, there's three systems. We have the arteries, the veins, and the lymph system. The arteries bring the blood from the heart to the different parts of the body. The veins bring them back. And between the arteries and the veins are the capillary system. At the capillaries, the blood and fluids are filtered into the tissue, and a lot of this is picked up by the lymph system and drawn back. So about 80%, 80 to 90% is brought back in the veins, but some of it's collected by the lymph system. Today we're going to focus on the venous system, which is going to be continuous with the artery system. So how does blood flow? This is a question that was initially people didn't know how blood flows. People didn't know there was a heart and a double circulatory system. So back in the Hippocrates days, people thought there was a separate vein system and an artery system. The veins occurred from the liver and contained the blood, which was the nourishment for the body. And it was thought that the arteries contained the spirit of life. It was a vital system. It was not known that these two systems connected. Then in 130 AD, the Galenic theory was that blood from the liver was from ingested food and flows on the right side of the heart, and some of the blood flows through invisible pores to the left side of the heart, where it gains vital spirits and it mixes with pneuma from the trachea. It wasn't until 1600 William Harvey actually explained the double circulatory system, where blood is pumped from the heart to the lungs and the body. But at that point, people still didn't know how the blood went from the artery to the vein. And finally, around 1650, the Italian Malpighi discovered the capillaries, looking under the microscope, that it was a continuous system from the arteries to the veins. So when we take a close look at the vessels, the arteries that you see here, it has a very thick, smooth muscle layer, which means that in sort of like a cross-sectional histological view here, you can see the smooth muscle layer here. So it's a relatively rigid tube, whereas the veins, you can see, does not have a very thick, smooth muscle layer. And you can see here it's a little bit collapsed. Thus, it's not very rigid. Also, it has the ability to dilate and become balloon-like. It could also shrivel down. And the capillaries that are in between the arteries and the vessels, unlike the artery and the veins, are made of one-layer endothelial cells. Thus, you only have one layer. It's very easy for the fluid to go in and out. Cells, nutrients, all of that exchange can be done at the capillary level. So just a diagram, you have the heart, where it pumps artery to the body, goes through the capillary system, comes back to the veins, comes back through the veins to the heart. It gets pumped into the lungs, and then comes back through the pulmonary arteries back to the heart. So it's a double circulatory system, and the lymph vessels act to collect the fluid that is filtered through the artery and the capillaries. So knowing that, what happens in the capillaries? So you have the single layer endothelium of the capillary, which can filter nutrients, cells, all of that through the tissue and back into the blood vessel. So in the artery side of the capillary, you have the high artery system, pressure in the high arteries, filtering fluid nutrients into the tissue. At the middle of the capillary, there's not a lot of movement, but when it gets to the venous side, where the pressure is very, very low, it reabsorbs all of that fluid. So when we talk about veins, how is the architecture of the veins? Specifically, we're going to look at the veins in the legs. So this is a cross section of the leg right around at this level. Sorry, this bar is a little off. It's supposed to be right around here. This is the femur, the bone, and you have the muscles around the bone. It is encased in the fascia, which is a capsule that surrounds the muscles. And you have the deep vein system, which runs deep within the muscles. Also, you have what's called the superficial system that runs outside of the fascia. These veins always drain into the deep system before going into the going back to the heart. So the veins that we see on the surface of our bodies, you may be able to see your own veins. The ones on the legs, especially, all of these veins are part of the superficial system. So when we think about how the blood flows from the legs back to the heart, there's really two key players. One is the calf muscles. So when the calf muscles pump, whenever you raise your leg and your calf muscles pump, it squeezes the vein so that the blood inside the vein will be pumped. When it relaxes, then the blood can come fill the vein again, and it squeezes and it gets pumped out. But how does the blood keep going the right direction? Well, there are veins. Our veins have valves, but they're one-way valves. So if the blood is pumped up, it will let the blood flow. However, the valves will close when the blood tries to go the wrong way. So it keeps going the blood in one direction. It's one-way valves. Knowing all of this, what is venous disease? What happens in venous disease? It's really mainly three things that are occurring. One is venous reflux, which I'll go into in a minute, but it's the veins that I just mentioned not working sufficiently. With the veins not working sufficiently, you're going to build a lot of back pressure, which creates high venous pressures. That's also part of what occurs in venous disease. Also, you could develop blood clots in the veins, which obstruct the venous flow. So venous reflux is what is caused by disease of the vein valves. So normally, if you have properly functioning veins, the blood will be flowing in one direction because it will let the blood go up, but when it wants to come back down, it will close onto itself and it will keep the blood flowing in the right direction. However, these veins can get leaky, and when that starts happening, down here you can see when the valves are not closing properly, some of the veins, the blood in the veins will flow backwards. When it does that, because the veins are the structure of the veins, as you saw in the initial pictures, there's not a huge muscle layer to keep them a rigid tube. They will dilate and become like balloons. So you have a ballooning of the vein. When the veins balloon, then the valves get pushed out further, and then you have more reflux. So it sort of feeds onto each other, the worsening of the vein valves and then the dilation of the veins. And when that happens, you start to get some inflammation occurring in the vein walls, and that activates some of the inflammatory cytokines, which degrade some of the collagen and the extracellular matrix supporting the vein walls, making the venous walls dilate even further. Also with that, you have some of the red blood cells extravasate into the tissue and cause inflammation there. Once there's inflammation in the tissue, that area becomes scarred. So what you will see in a patient with long-standing venous disease is skin changes, tissue changes that occur with the long-standing inflammation. So how does the venous pressure change? When we're lying down and we have our legs at our heart level, the pressures are very low. It's usually on a magnitude of 10, 20. But when we stand up, all of a sudden we have our weight, gravity applying onto the pressure, onto the venous pressure, so our venous pressures rise. However, when we start walking, because the calf muscles are pumping, the pressure in the veins will drop again, and if you stop, it goes back up. What happens when you have vein valves that are not working properly and causing reflux is that the pressure, even when you walk, because a lot of it's refluxing, you're not going to have that drop in venous pressure. So you're constantly in a state of high venous pressures. And what happens to the veins when they're always under high venous pressure is, this is I do this, so it's not the best looking schema, but what happens is, this is the vein, this, you'll think of this as the muscle, this is the skin layer here. So some of the blood will backflow, causing high pressures into the veins, and that causes vein dilatation. So if it happens in relatively large veins, you may see them as varicose veins. You'll see these squiggly, tortuous veins from your skin. If they happen in the very, very small veins, you may see them as spider veins, which are more, it's the same pathophysiology, but it just occurs in smaller veins, so it's not tortuous, but you would see these, the veins especially on the thigh, calf, ankle areas. So what happens when the veins dilate, when you have varicose veins, when you have spider veins? Sometimes nothing, sometimes it may just be an appearance. You have unsightly legs, but sometimes because of the inflammation in the vein walls, you could have a lot of symptoms. For example, pain, aching, crampiness, heaviness, restlessness. It's not usually a sharp pain, but more of a dull, long-lasting pain. It can cause fatigue, it could cause your legs to be swollen. Sometimes it's burning because of the skin changes, it could be itching. And then you may see browning of your skin. I always think of it as like a water balloon. So if you have a balloon, which is like a vein, it can change diameter in relation to what's inside. And if you hang a balloon, all of that water is going to pool. So if you think about chronic venous disease, you can think of it as a lot of the blood pooling like a water balloon if you hang it. So what you may see is, you may see swelling of the legs, you may see the varicose veins, you may see skin discoloration because of the constant inflammation that's occurring, and you may also see skin ulcers. These are skin breakages, which occur because the tissue has become so hard and brittle with chronic inflammation. So how do we find these? Varicose veins, spider veins, you could see them from the surface very easily, but do we know how much reflux there is? Where is the reflux? That's when we use duplex ultrasound testing. So it's a non-invasive way where we put an ultrasound probe to the legs, and we scan the veins to see how much reflux there is. So if the veins are closing properly, you're not supposed to see any reflux. So all of this mountain here, the wave that you're seeing here, is the reflux that this patient is having. So at what we call the saphenofemoral junction up here, this patient has a lot of reflux, and also at the great saphenous vein, there's also all of this reflux. In a normal, competent vein, you would not see all of these reflux. So when did we first know, or when did we first find out that there could be problems with veins? It goes really, really back. There's ancient Greece, it's not a sculpture, but these findings where you have men holding onto a leg with a tortuous vein, obviously a varicose vein. There's caveman drawings with some varicose veins, some drawings of ancient Egypt with varicose veins. So it's very obvious. You can see them from the surface. So people have known that these existed for a very, very long time. So what do we do about them? Actually, the very first sort of written, something written about these veins in relation to venous ulcers was Hippocrates. And he noted that when you have these ulcers in your legs, although he didn't know exactly what venous hypertension or veins were, he knew that if you wrapped them, they would heal. So compression stockings have been around since the time of Hippocrates. You would compress and wrap the legs up, and that would actually cause a scaffold around your legs. So instead of your veins ballooning up, your legs ballooning up, it creates a scaffold so that they are somehow contained. And with this, because when wounds occur, wounds, for it to heal, the wound edges need to come together. But if you have the leg that's swollen and trying to pull the wound edges apart, they're never going to heal. So the compression really works to get that pressure down. And it's been done since the ancient times. Now we have compression stockings that are graduated, have certain pressure measurements applied to them. There's devices with Velcro you could wrap on. And you can see this is a patient who had one leg wrapped and one leg was not wrapped. It's the same patient, same leg, but one had compression, one did not. So if you have venous insufficiency and swelling, you can see that the compression therapy really works. So in terms of other treatments besides compression, what did people used to do? So because it was an easy target, you could see the varicose veins from the surface, even in ancient Roman times. People tried therapies where you pull out the vein. So there are drawings of veins being pulled out. Obviously, in those times, there was no anesthesia. There was not a lot of good infection control. People bled from these horribly, got infections. It was very, very messy. So for a period of time, these were performed, then they were not performed, went on and on. Even in the 1700s, 1800s, people were pulling out veins with hooks, these varicose veins. They are very similar to some of the instruments we use now. We still use these hooks. So the treatment of pulling out veins were started over 300 years ago, and there's still some parts of that treatment that we do. Initially, surgery for veins were stripping. So you were stripping or ligating. So you would ligate off the vein that was causing a lot of the reflux, or you would pull the veins out. You would use what we call strippers. There's a picture of this down here. These wires would be guided in through the vein, and then at the tip you would attach this little head, and then you would pull the whole vein out of the leg. It could be very bloody, and it needed to be done under anesthesia. It's still done nowadays. It's not like that it's a bad surgery or anything like that. There are indications for vein stripping even now, but we've moved to less invasive ways to treat veins, and now we treat them by using catheter-based therapies. So instead of taking the veins out physically, what we do is we leave the veins in place. However, we place a catheter through the vein that causes a lot of the reflux, and we emit heat from the tip of the catheter. It could be radio frequency, it could be laser, but some kind of heat that burns the vein down as it closes them. So you're putting a catheter in the leg, you're emitting heat, and as you pull it out, the vein closes and collapses. So you shut off the vein that's causing a lot of the reflux. Another treatment is If you have a relatively straight vein that's causing the reflux, you could do a catheter ablation. However, if you have very, very tortuous varicose veins, it's hard to put catheters and ablate them. So there would be treatments where we pull the veins out. These are called phlebectomies. We make little nicks in the skin, and then we use tiny hooks to take the veins out. Also, for the tiny, tiny veins, the spider veins, we use a treatment called sclerotherapy. We inject with very small needles into the veins a sclerosing agent, which also collapses the veins. So these are all methods to collapse the diseased or dilated veins. A lot of people worry what happens if you get rid of or collapse the vein that's causing a lot of reflux. How does the blood get back to my heart? Well, we have a lot of veins, so even if you close off the refluxing vein or the diseased vein, the blood will always find another way to reroute itself into the deep system and back to the heart. So the other venous disease is blood clots. This is a little bit different than the venous reflux. But blood clots occur often. You may hear about DVTs. This is for deep vein thrombosis. So now we're talking about the deep vein that runs deep in our muscles. Blood clots can develop in the deep veins, and this could sometimes be fatal because if they are in the deep veins and just in the legs, it's fine. But these can travel to the lungs and cause what's called pulmonary embolism. And because the deep veins are a straight shot through to the heart and to the lungs, these blood clots that break off from the legs could dislodge, go to the heart, then to the lungs, and cause massive pulmonary embolism, which could also cause circulatory collapse and sometimes be fatal. On the other hand, if you survive the acute stage of DVT or pulmonary embolism, you could still have later complications known as post-thrombotic syndrome. So if you have a blood clot that's obstructing the vein, and it's similar to reflux, you're having something there that's causing a lot of back pressure, high pressures in the venous system. With that occurring for long periods of time, you still get the same symptoms you would get with venous insufficiency. The skin changes, the ulcers, the swelling, the diseased and dilated veins, and this is similar pathology, but this is called post-thrombotic syndrome. So what causes the blood clots in the veins? Virchow talked about how blood clots are formed. There's usually a triad of things. It's stasis of blood flow, meaning there's something stagnant in the blood flow, endothelial injury, meaning some injury to the vessel wall, and hypercoagulability, which is usually something inherent. There's some blood clotting factors in your blood that causes you to be hypercoagulable. A lot of the times you may hear of DVTs following surgery or long plane rides. That is because you've been in a stasis, blood stasis flow. You haven't been moving. That could be a trigger for DVT. Also, if you have certain factor V Leiden, any kind of other hypercoagulable propensities, you could also develop blood clots. And then once you develop blood clots, you've developed endothelial injury within the vessel. So once you have a DVT, you're prone to have more DVTs because the continued endothelial injury will provoke new clots. So how do we find these DVTs? Again, it's with duplex ultrasound testing. On the top here, this is a normal vein. So this is the vein, this is the artery. Like I said, the arteries are pretty rigid. So even if you press on them, they don't collapse. Veins are are like balloons. You can collapse them very easily. So if you have a vein that's completely open, you take an ultrasound probe and press on top of the vein, you will see it collapse completely. However, if you have a blood clot there and you press on the vein, it's not going to collapse completely because there is the blood clot there. that is how we test for DVTs in the legs with the ultrasound. So when was DVTs first noted? It was the first writings of DVT is from 1271. There was a young man, Raoul. He developed calf pain, which extended to his thigh, and most likely a DVT. How was it treated? This was a miracle, because what happened was he went to the tomb of King St. Louis and prayed to the saints, and miraculously he healed his ulcer. But that's not the way usually DVTs heal. What's been done historically, there's been a lot of treatments that are completely abandoned now, but things like bloodletting, I don't know if you've ever heard, these were treatments where you nick the person to bleed them out. So it could be bleeding out bad humors or something where you're bleeding things out. These used to be, actually, George Washington, when he was he died from bloodletting. He actually had an infection, but to treat the infection, he had bloodletting, and he probably bled to death in some way. But these treatments were done. It wasn't until the late 1800s that there was a petition against bloodletting by some physicians saying that this was an inappropriate treatment, but these were done. Also, in the old days, there were leeches. So you would put leeches on and have the leeches suck the blood out of you. This treatment is still actually done for certain post-surgical blood congestion in flap surgery, but these were done for DVT treatment. And also in the old days, whoops, sorry, I did that again. It was thought that when you had a blood clot, you shouldn't move. So you should be immobilized. So there were these whole body casts that people were put into so they don't move, so the blood clot doesn't move. Now we know that if you have a blood clot, you actually should move. Early ambulation is very important, but historically people did not know that, so they were put in whole body casts. Medical treatments. So medical treatments really started in the last century. In 1916, which would be exactly 100 years ago, J. McLean, he was actually a medical student, a second-year medical student at Johns Hopkins at the time, when he discovered heparin. Heparin we know right nowadays as an anticoagulant, but in those days what they were looking for was a procoagulant, something to stop bleeding. He was working in a lab with Dr. Howell looking at properties for procoagulants when he discovered heparin. It didn't go into clinical use until the 1930s, but that was when heparin was initially started. So infusion of heparin acts as an anticoagulant. What it does, if you infuse it when you have a vein clot, venous thromboembolism, is that it prevents new blood clots from happening. Some people think that it dissolves the blood clots. It does not dissolve the blood clots. It just prevents new ones from occurring. And then in the 1940s, warfarin was found. Initially, the history behind warfarin is very interesting. I don't have time to talk about it today, but it was discovered because cows eating sweet clover were bleeding, and it was a substance in the sweet clover called coumarin that made them bleed. So then the coumarin was used for rat poison. So initially, warfarin people thought it was rat poison, and why do we use rat poison to treat people? Initially, it wasn't used to treat people. But we found that it can be safely treated, safely used. One of the reasons why is there was a man who took a high dose of warfarin, just took warfarin pills. And I think he tried to commit suicide, but he didn't bleed to death. And that made people think, oh, warfarin may be actually safe to use. And now it's used very commonly as an anticoagulant coagulant for DVTs, pulmonary embolism, also for atrial fibrillation. But warfarin requires very close monitoring, and it interferes with foods that you take. So it's a good medication, but it's very hard. It could be very hard to take for some people. So most recently, a little over 10 years ago, some of the novel oral anticoagulants came onto the market. They're called direct 10A inhibitors or thymine inhibitors, and these are drugs that require less monitoring and but have not completely replaced warfarin for several reasons. We won't go into that too much now, but right now the medical treatments for DVT is usually warfarin or one of the novel oral anticoagulants. Also, surgically, if you have a migrating blood clot, you're worried it's going to travel. What did people do? So there were times when, in the old days, people just ligated the veins, but we know that didn't work. Then people tried to plicate the veins, so you're plicating it so the veins, the blood clots don't travel. There were clamps that were put on the veins. There were filters that were put in. These are all filters, clamps. These are all done in the veins in the abdomen, the inferior vena cava. But then there are also these IVC filters, the inferior vena cava filters that were started to be placed around the 1970s. These are to prevent the blood clot. So what it does is it sits in the veins, and if the blood clot wants to travel, it traps into them. These are still commonly used. However, these can also be dangerous. So there's very limited, there are certain circumstances you want to use the IVC filters, but they're not regularly used. It's very interesting because if you type IVC in Google, you will, before you find any medical treatment, you'll find lawyers come up because there's been so many lawsuits with IVC filter issues. But it is a treatment that is still used for certain circumstances. Then there's also catheter-directed thrombolysis. With the advancement of all these endovascular treatments, we can put a catheter in there and lyse the vein, lyse the blood clots, meaning dissolve the blood clots and suck them out. These are new treatments that are still under investigation. We know it works for some veins. We don't know if it works for the leg veins under distal to the groin. But these are some of the treatments that we are looking at for future. And so overall, I gave you a summary of what venous disease is in terms of venous reflux, chronic venous insufficiency, DVTs, and what's in the horizon for these diseases in the future. A lot of it is endovenous therapies, where catheter-based, less invasive therapies than surgical therapies. Surgery still plays a part, but there's less invasive surgeries. Also, new and safer anticoagulants to take. And also, one of the things that I am personally interested in is looking at genetics of these venous disease, because we know a lot of these varicose veins can run in families, DVTs. Also, there could be a genetic component of why some people develop DVTs and have horrible post-thrombotic syndrome versus some people clear them very well. And these are studies that need to be done on a large population basis. But now there are large biobanks that collect a lot of data, blood samples from patients to do GWAS studies and things like that. So that I think is the future of venous disease. There are the procedures, but we really want to hone in on what is the underlying cause of it. And I think looking at these population studies and studying the genetics will give us some light into what we could do further. Thank you very much for your attention.
on the microphone.
If you want to use the handle.
We can do that. Do you have some questions? Does warfarin have anything to do with the blood flow that you were talking about before? Does it change anything?
So the question was, does warfarin change the blood flow? So warfarin actually is called a vitamin K antagonist. So what it does is when the blood clots in our bodies, it goes through a coagulation cascade, and warfarin blocks a lot of the coagulation the vitamin K dependent coagulation factors. Those would be factors 2, 9, 7, 10. These are the factors that warfarin blocks. So what it does is it doesn't change the flow, but what it will do is it will prevent you from making clots. So not prevent you altogether from making clots, but it will make it harder for you to make clots. The good thing is it'll prevent the blood clots. The downside is if you bleed, it takes longer to develop the blood clot.
Thank you.
Is it known what starts the problem with the valves?
So the question was, do we know what starts the problem with the valves? So this is sort of the million-dollar question. We're trying to figure that out. There are a lot of risk factors that we know of. Obviously, increased pressures from the upper body. Pregnancy is a big risk factor. It looks like people with standing jobs, teachers, nurses get them a lot. Also, it does run in families. There's been studies that show that if you have both parents with varicose veins, the likelihood of you having a varicose veins is close to 70%. This is one study. It's not proven to be replicated, but so there are environmental factors and risk factors, but we don't know exactly what causes them to start the reflux.
Wearing compression stockings, is that really a good idea? It seems to me wearing them below the knee makes pressure to above that, you know?
So the question was, wearing compression stocking, is that good because it creates like a tourniquet, you're saying, and for above the knee. So the compression, what it does is, in addition to holding the veins and the legs from swelling, it actually causes the scaffold that the compression creates, the muscles, when they pump against that, it makes the calf muscle pump more effectively. So that works. And the main part that really drives the blood flow from our legs is our calf muscles more than our quads or anything up in the thigh. So wearing that compression knee high really helps. If you could wear thigh high ones, those are more helpful in keeping the legs from getting swollen. But in terms of enhancing the calf muscle pump, it really is very effective. Sure.
Does cholesterol affect venous disease? And the second part is, are there lifestyle, exercise, that kind of thing, that you can do to either calm it down or prevent it altogether?
Okay, so first question is, does cholesterol affect venous disease? Cholesterol usually affects the arteries more because the cholesterol buildup that we see, atherosclerosis, mainly occurs in the arteries. So if you could have very, very severe artery disease and nothing wrong with your veins. You could have, so one of the main drugs that is used to lower cholesterol, the statins, have, it's sort of like a miracle drug. It works for everything. It does lower cholesterol. It works for atherosclerosis. There are studies that look into if you're using statins, does that help in preventing post-thrombotic syndrome, DVTs, but nothing definitive coming out saying that any manipulating cholesterol or being on statin drugs are helpful. And your second question, what kind of exercise should you do? So really the important thing is the calf muscles. More than biking or anything like that, regular walking is very good. The walking really helps with the ankle movement, and then when you move your ankles, that stepping off, that kicking off, squeezes your calves. Biking is really good just for overall cardiovascular, but it's more your quads, your glutes, so it doesn't work the calf muscles as much. Obviously, leg elevation is always good. One of the exercises that's probably not that great for venous disease is anything with high pressure. So if you have a very large barbell and you're doing military squats or like something like that, you're adding a lot of pressure and doing squats, those are probably not that great for the legs. But anything that pumps the calf muscles are very good. And some people ask me, well, what happens if I lose weight? Actually, weight loss is also a very, very important component of getting relieving your venous symptoms, because for every 1 pound of weight you have on your upper body, the leg feels about 4 pounds more. So if you lose 5 pounds of weight, your legs will feel like it lost 20 pounds. It's much more the effect of that weight will feel significant on your legs. So that's also as important as exercise. Yes?
Are there any studies for anticardia with an antibody syndrome here that a person can get involved in?
In terms of for vasculitis, or I'm sorry, I will repeat the question. So her question was, is there any clinical studies for antiphospholipid antibody syndrome? Antiphospholipid antibody syndrome is one of the thrombophilia diseases that I was mentioning about. I didn't go into that, but it's a blood clotting. It's not a blood clotting disorder, but if you have these antibodies, you could be more prone to blood clots. I'm not aware, I myself am not participating in any studies, but there may be if there, I think if you can look into clinicaltrials.gov, and also Stanford may have some studies. If you are interested, we can definitely try to help you find some studies.
We'll help you find that.
Mm-hmm.
The health library will help you find clinical trials.
Mm-hmm. Yes?
And high blood sugar also is.
So how does high blood sugar affect the veins? Usually, again, the high blood sugar affects the arteries more than the veins. The blood sugars, what it does, it affects the big vessels, but when you have uncontrolled diabetes, it tends to affect the smaller arteries more. So you may have small vessel disease. It could be in your legs, it could be in your eyes, it could be in your kidneys. And when the sugars deposit on your nerves, you could have neuropathy. But there's not a direct correlation between venous disease and high blood sugars. Go ahead.
Two patients with venous reflux.
Mm-hmm.
We just manage the varicose veins. What about the deep veins? How is it necessary to repair the deep veins well? Is there any effective method?
Mm-hmm. That's a great question. So the question was, I talked about all the treatments for the superficial veins. If you have venous reflux in the deep veins, are there any treatments? The reason why I didn't talk about it is because there are no treatments for the deep venous system. Unfortunately, if you have valvular reflux in the deep system, at least what we can do for now is compression. Things like valvuloplasty, where you try to plicate the valves and reconstruct the vein valves, have been tried, but it doesn't seem to have a good outcome. So the reflux treatment is mainly for the superficial veins. Mm-hmm. Go ahead.
Like the ballooning of the aorta
Mm-hmm.
or ischemic disease in the brain,
Mm-hmm.
is related? Or stroke?
So these again they're all part of the circulatory system, but these are disease on the artery side. So it has to do a lot of the ballooning. For example, the aortic aneurysms. Some of it is genetics. It could be smoking, could be a risk factor, but it doesn't have any specific relation to the veins. Also, stroke, it doesn't have, as far as we know. There may be things that we find out with genetic, studies, but right now there's no specific correlation. Go ahead.
Hi, I wanted to ask you about swimming.
Mhm.
It's, if you use a kickboard
Mhm.
and use those just mainly kicking,
Mhm.
would that be another good exercise, would you say, for that? Or is it
I
just weight bearing?
I mean, swimming overall, for overall health, is excellent, but I'm trying to think if that would, how much of the calf muscles you would use with the kicking. If you're like a really good kicker and you flex your legs really well, you may, but just regular walking will probably do the trick. Yes?
And the compression stockings,
Mhm.
they come in different pressure numbers.
Yes.
Which one do you supposed to use?
So the what pressure compression stockings should you use? So the recommended pressure for the venous disease is 30 to 40 millimercury. However, 30 to 40 millimercury compression stockings are pretty tight. If you're trying them on for the first time, you're going to have a lot of trouble putting them on. If I recommend it to people, they buy them, they tell me it's too tight, I didn't wear them. So I usually recommend starting at 20 to 30. And if you are tolerating it well and you could go up even more, then you could go to 30 to 40. But as a starting point, 20 to 30 would be a good point. Yes? Oh.
Excuse me, go ahead.
To
Uh-huh.
add to that question about compression stockings, I've
Mhm.
seen and I own a pair of the running
Uh-huh.
compression stockings.
Uh-huh.
Can you speak to how those?
Sure. So the running compression socks, they're the athletic sleeves. They start mostly at the ankle. I think they're all effective. They're much better than nothing. And a lot of people who don't want to wear the beige-looking socks want to wear the sportier ones. I think that's good. If you have just mild reflux, that's okay. If you have pretty severe reflux, you want the graduated compressions to start really at the ankle. So if you wear the sleeve and you already have a little bit of swelling, that could cause a tourniquet. So for mild venous reflux or mild venous insufficiency, that's good. But if you have relatively severe or advanced disease, I would start with ones that start at the foot. It could be an open toe or a closed toe, but the ones that start at the foot. Do you have a question, sir?
Yes, what was the name, what the unit of measurement, you said 20 to 30 and 30?
Millimercuries.
Pardon?
Millimercuries. mmHg, millimercuries. Millimercury.
Okay, thanks.
And where do you purchase these?
So these could be purchased either at a medical supply store or they're also available online. There's a lot. If you search for compression stockings, there's a lot of sites that sell them. They're on Amazon. There's certain stores that are dedicated to these. You do need to size them appropriately, so you would need to get a tape measure around your ankle, your calf, your leg, and go with the sizing that's on the description of the packet. Go ahead.
When you sit on an airplane,
Mhm.
you know, for a zillion hours,
Mhm.
and your ankles swell up. When is it a matter of concern? When is it a sign that it is venous disease or something else, or is it just sitting for way too long?
So most of all of us, if we sit on an airplane without moving for 10 hours, we're probably going to get swollen legs. Our feet are going to be very tight. That's normal. Everybody's going to get a little bit of a swollen leg when they're on an airplane. But if, for example, when you get off the plane, you're having calf pain or some kind of tightness, even after you're off the plane, you're walking around, it still doesn't go away. Then you get a little, suspicious, is there anything going on? But if it's just a little bit of swelling at the end of the flight, that's probably within normal limit. Yes.
In regards to that same thing,
Mhm.
do you think it's a good idea to exercise your ankles in that while you are flying if you're on the wing?
So what I recommend to my patients especially the people who've had DVTs, is all the things that you really usually don't want to do on a plane is like drink lots of water, walk up and down. And so that's really important because when you walk, you're circulating and also drinking water, keeping hydrated, keeps the veins from becoming concentrated. So those are really key walking around. And if you can move your ankles, all of that's really good.
So water in general then is very good.
Well, you don't have to go crazy, but just keeping hydrated because most people tend to not drink water when they're on flights because they don't want to go to the bathroom, but you don't want to hold back.
Thank you.
Yes.
Is there herbal medication or Chinese medication for varicose vein, how to relieve a little bit?
A Chinese medication for varicose?
Herbal medication.
Oh, herbal medications.
Yeah.
So
Which is alternative medication.
alternative medications.
Yeah.
So with any alternative medication, it's not as studied as rigorously as other treatments, but some of the things that have been thought to be helpful, for example, is horse chestnut seed extract for leg swelling. These herbal medications are usually more tried in Europe or Asia, not so much in the US, but one of the highest evidence for the herbal medications is probably horse chestnut seed extract.
I think you have time for one more question.
Okay. Okay.
Well, is there, for varicose veins, is it recommended to get surgery on them?
So the question is it recommended to get surgery for varicose veins? I always tell my patients that you cannot die from varicose veins. So it's really a matter of what's bothersome to you. If you just have varicose veins that are unsightly looking and you don't care how it looks, no need to do anything at all. Even if you don't have unsightly varicose veins, you may have a lot of swelling, and we found on ultrasound that you have a lot of venous reflux, then it may actually help you to get the treatment because it will help you with the symptoms. And some people may have a little bit of fatigue, heaviness in their legs that doesn't bother them. They don't have to do anything. But if you have something that bothers you, we try to help you. So it's really a lifestyle disease. It's not a killer like the arteries most of the time.
Thank you, doctor. Really informative.
Thank you.